looking forward to this last and symptom management. Though there are many symptoms we could cover, but we were limited maybe just to look for those we have seen more common. So I'm not doing well. I've just catch up. It's Malignant flu, but I hope we will manage through. So today we will have a case presentation from RFM. So maybe we go to, before we go to the presentation, let me just say in our last session we were doing pressure answers or looking from the perspective of healable wounds. So today we will be looking from non-healing wound or chronic or malignant wounds. So we'll be looking at that. So let me share my presentation for today. And I'm hoping Wi-Fi won't let me down. Chances are high that I might lose the picture, but I'm hoping we will manage. So here we go. So yes, yeah. So there we go. So today we're looking at the palliative care wounds, or those wounds that we are not going to treat. So we'll look at factors that will normally interfere with the normal healing, and then we'll describe basic principles of wound management, and then we'll look at approaches to manage palliative care wounds or palliative wounds, and then we'll discuss the best clinical practice for chronic wound care that we all know. I'm aware that we all know this, and we will share best experiences together. But just to share that we have 3 wounds that are normal. So we have healable wounds, and then maintenance wound, and the non-healable wounds. How much we wish that all wounds could be healable, meaning that they have adequate blood supply to support healing, and the cause of that wound could be optimized or corrected. How much we wish all wounds would be like that. And then we also have maintenance wound. Normally these wounds could be healable, but due to different factors, maybe healthcare system related factors or patient related factors, and then this wound you'll find that we end up maintaining because we don't have sufficient resources to manage, or the system has some bottlenecks in terms of dealing with that wound. And then we have non-healable wounds, which are most common in cancer and or with palliative care conditions. And these ones, they do not have adequate blood supply to support healing. And normally the background cause cannot be reversed or corrected. So we call them non-healable. And they are the most that are so distressing. So then the factors that normally prohibit wounds include medications. You will find that some patients are taking certain medications that has to reduce or compromise the immune systems, like corticosteroids. If a patient is taking corticosteroids, you will find that now for the wound to heal, it requires the immune to be stronger, but in this case, corticosteroids are the blockage. Another one is malnutrition. So the issue of malnutrition, especially patients who are approaching their end of life, we know that they have reduced protein or calorie intakes, and sometimes they end up NPO due to progression of condition in their situation. So most of the time when the patient is not eating well, you find that then healing that wound would be very difficult. especially when the proteins are not there, vitamins are not there. Another inhibiting factor for the wound to heal, the environment, there must be enough hydration. So dehydration is another stumbling block towards healing the wound. So when my patient is always dehydrated, of which sometimes when they are approaching the end, they end up becoming dehydrated. And you find that then there are these ethical dilemmas. Then you say, should we rehydrate artificially, or we maintain the status of the patient, or improve the quality of life as per patient need? So dehydration sometimes becomes a stumbling block. Some of the patients, they end up developing edema due to poor circulation, and then due to that, then we say that also edema affects the wound healing process, especially when it comes to the issue of blood circulation and perfusion. So when we say that, then edema goes together also with reduced or diminished perfusion. They also call it hypoperfusion. So there's not enough blood reaching the cellular level. And then also when the patient has those chronic conditions and other conditions like diabetes mellitus and chronic heart failures, you discover that once they have these wounds could be healed, but then because of these conditions, the wound cannot be healed. And then also immobility, poor functional status of the patient. When patient become more bedridden and they cannot exercise, and then you find that if they have a wound, it reduces the chances of the wound to heal. So these are the things we need to understand that patients go through. Some of these factors, we find that when they are there, we cannot reduce or reverse them. So then the question is, if we know these are some types of the factors, why do we then need to do wound care? The first goal is to provide treatment. So treatment, we mentioned like we treat the wound that we can see, or we deal with the underlying disease. Like that. For that reason, we have people going for chemo, going for dialysis, all those issues that are done to improve quality of life as treatment therapies. But we know with the model of palliative care, sometimes their efficacy is reduced over time. But for that reason, we provide good care for treatment. But then for non-healing wounds, we want to maintain stability of the wound. We don't want it to progress. So we want to keep it stable and not progressing. And then we have want to promote healing, which is then we have to provide the most interactive wound healing environment for the wound to dry. We don't want it to be very wet. We don't want it to be dry. And then also we know that the wound base normally has a lot of there's a lot of ischia or oxidate there. So we want to relieve the bacterial burden, because most of the time the infection of the wound is the one that delays healing. So we want to reduce bacterial burden by all costs to give the body the opportunity to thrive through. So sometimes we control some certain symptoms that comes with the wound. We deal with the exudate, we deal with the pain, and then we deal with the udo. And some of the wounds, especially cancer-related wounds, sometimes we deal with the bleeding. So that's what we are trying to do when we're doing treatment of the wound. And then also we go for prevention, which we are trying by all means to do wound care to prevent the skin integrity, and we prevent the wound from pressure points or being compressed, and also dealing with edema. And then also another thing we are trying to do when we are doing wound care, we are trying to improve the body image of the patient. This is the psychological part of the action. So we are dealing with the body image. We know once a patient has wounds, they begin to lose self-esteem due to the odor, the exudate, the pain, and everything that comes with the package of a wound. And then also we are dealing with the psychic distress that brings by the wound, especially to the patient and sometimes the caregivers and the family members. My experience, you find that when there's a serious wound, the relatives end up running away from the patient, leading to what we call isolation and neglect by loved ones. So by wound dressing, we're bringing all friends closer and chasing away the flies and other enemies of the wound. So there are principles that guide us when we are doing wound care. Is that when we're doing wound care, we need to keep the wound moist, not dry, not wet. So when we're doing it very well, we'll keep our wound moist. And then we also manage drainage. Some of the wound, you find that they are draining a lot of oxidate. So what is happening, the oxidate moves from the wound base and then goes up and ends up corroding the peri-wound on top and then corroding the skin. So we are controlling the drainage. We don't want it to flow either way. We want to contain it and then take it away. And then also we are talking about feeding wounds. We don't leave wounds open and in hollow structures. You know, some wounds, they go deeper up to the level of a muscle, like we shared last week, the stages of the wound. So we are controlling that and we are filling those holes with dressings. And when we are doing that, we are not putting all things there. I usually call them put rocks there, like we are creating foundation, because that one will lead to our bulletin to protect the wound from trauma. You know, we don't want it to be traumatized now and then. When we are dressing, is bleeding, our dressing is bleeding. So that means your wound is not protected from trauma. It keeps on getting traumatized now and then. Another thing we do wound healing is to do wound dressing, wound care, is to assess the healing process, to determine if our wound is healing or not, to determine if our interventions are meeting the goals we were doing it for. So then we have wound healing basics. As I've mentioned before, wound do best in a moist environment, not in a wet environment or dry. So in fact, that there were interventions used before that will keep the wound very dry. But this time around, I said, no, don't keep the wound dry, don't keep it wet, but maintain a good environment for the wound to dry. So let it be moist. Loosely pack when needed, because tight packing then leads to the damage, as I've mentioned. And then also I've mentioned that the basic is to protect the peri-wound. So at this point in time, we have hydrogels or barrier films. Those lotions then you can put around the skin to ensure that when oxidate comes, then the peri-wound is not damaged. And then we clean and irrigate before assessment, because we don't want to make a judgment yet. The real issues just behind the oxidate that we see then. And then we pre-medicate for pain before dressing changes. Always we encourage even the clients, relatives, or caregivers that no, prevention of pain is very more important in wound care. So let's prevent pain before we begin dressing, unless the patient cannot feel pain at all. If culture is needed, we say that we must clean the wound thoroughly before swabbing, so that we can get the real wound-based culture. Okay. So we are saying then we cannot culture the dressing, because the dressing contains dead materials. So that we want live material, so we need to take away the dead and then left with the good one. So sometimes we find that the wood is beginning to give granulation. So we swap it so we can tell what is happening. So every time we're talking about dressing, we will have time to select the product that we're going to use for dressing. Some of the things that influences us on what to use for dressing is the frequency of change. Certain dressings, they require to be there for 48 hours, 72 hours, you know. So yeah, some will be on 8-hourly basis. So it depends on what is the frequency of change. So we can know how frequently are the caregivers or we as clinicians will be available to change the dressing. Number two, we look for the ease of the procedure. We don't want dressing that are so complicated, because we know palliative care patients are not cared for by clinicians alone, but also by the caregiver. So we want a very simple dressing model or procedure that even a layman caregiver can understand. And also we look at the caregiver's ability. At hospice, when we are doing our assessment of the caregiver, we normally look for their skills that they have. and rate it. We'll see how much skill do they have to do the caregiving that they are supposed to provide. So that will give us the opportunity that we know that this one is has limited or it has a proficient level. So then we are able to know how much to train and how much the patient needs support. And then availability of products, we don't prescribe some material that are not available or affordable. For that reason, sometimes you may need alignants, but alignants are very expensive. So sometimes we look around those issues on will the patient afford this dressing, because what we need to know is sustainability, especially to chronic wounds, because she might or he might need that dressing for a long time. So we need to understand this. And then the dressing purposes, we also consider them. Most of the time, the dressing is to absorb drainages. So we need to know which dressing will do that best for us. Sometimes to prevent contamination, so we don't want that the external environment particles get into the wound. To prevent mechanical injury to the wound, so we know that now this is the fragile wound, prone to bleeding, so we don't want to prolong that one. So we know which dressing we can put there. To help maintain pressure to prevent excessive bleeding. Sometimes the patient has a wound that is bleeding, so we know what dressing are going to use to maintain prevent excessive bleeding. To provide the most wound environment, also if the wound is dry or is wet, and then we know what to use to provide the most environment for the wound, and then to provide comfort. So those are the things that we are looking for when we are choosing a dressing. So then when we are looking for the non-healable wound, these are one of the ones that are so distressing, because normally, even if the patient thought they will be healed, but knowing that a non-healable wound, we cannot reverse the cause, and all factors are saying that it cannot be healed. So as I've mentioned before, at this point in time, we are trying to reduce progression, especially found that maybe until we cure the cancer behind, and then the vaginal wound will not go away. I have another client who refused to take chemo, and then he has cervical cancer that has gone that far that the wound has come to the perineum, and then they refused to continue the cancer and opted for traditional medicine. Unfortunately, hemolysis continues because cancer devours the blood cells. They sometimes have to go for emergent blood transfusion. But what I brought here is that the wound, saying that it is healing, yet it was not healing, it was just getting more drier and drier. So another thing that happens with the malignant wound is that we are reducing the bacterial bedding. We don't want the odor. When the wound has a lot of odor, we know that now that means the wound base is a lot of bacterial bedding, so we need to do that. And most of the time, once the bacterial bedding increase, it comes with the wound. I think all of us have seen wounds that are chronic that comes with the bacterial bedding with a very, very strong odor. And most of the time, they also come with oxidate and with more severe pain, bleeding, and they have reduce the body image. So we want to do the opposite of that and then improve the caregiver skill of managing such wound. You know, when you have left them with that odor out of the room, you find that they are very happy and they appreciate what we have done for them. So it's very important when we are managing. Also, we help our clients to understand that normally, these are the goals of dressing. So they can know that when the odor is not there, when the oxidate is reduced, when they are not feeling pain, when the bleeding stops, they know that we are hitting the milestones and they will appreciate that. So when we are reducing the bacterial bedding, normally we will also share what we normally use. We normally use anaerobic bacteria. Okay, most of the wounds, normally we find that they have anaerobic bacteria, which responds well to metronidazole. So we use metronidazole liquid or crush to dress those wounds, and or silver dressings or silver pregnated dressings, adaptic kungaba calcium malignant or any girls pregnant with silver. Silver acts as an antibiotic. So metronidazole comes with two things for the wound. It comes with the antibacterial effect and comes also with the smell control. For that reason, it's one of the wonder drugs in palliative care. I know in a hospital setup, there's competition over metronidazole used for treatment therapies for systemic infections, but also we use it for wound dressing. And also the tissue depth. We look at the tissues and then we use topical microbials or systemic antimicrobials, looking at how deep is the bacterial infection. As I've mentioned that we also use malignant dressings with or without silver, because the malignant have calcium in it that exchange with the oxidates and absorb it from the wound. Yeah, and they are good for, malignants are good for wet wounds. Then we have metronidazole gel, but sometimes we don't have metronidazole gel. So if there's a pharmacist, they can help us make it 1% gel, but then if we cannot buy it, we can make it for ourselves, which is a concentration of 100 milligrams of metronidazole per 10 ml of hydrogel or a KY gel. So hydrogel, sometimes they are there to protect the peri wound when you are dressing, then you apply them on the skin or the peri wound to protect from the skin from maceration by the oxidate. So we use the same thing, we apply the KY gel, and then you crush the tablets, and then you put them in that jelly, you make that lotion, and then you apply to the wound. Sometimes you may add morphine sulfate syrup to make the compound. What we need to understand is that metronidazole inflicts a certain amount of pain, so it's very important that we use also pain medication. For that reason, you find that when we have done, we have put morphine sulfate lower doses, you will find that then the patient will feel well without feeling the pain that is caused by the metronidazole crush. Then we have topical antiseptics. These agents delay healing and decrease bacterial bedding and are toxic to the viable cells. So there are two things we need to understand with these supplies. When we are dealing with healable wounds, they are not a go area. So we don't have to use these supplies, especially when the wound is healable. But then for non-healable, at some point, you may use them. Let me make an example. You have a non-healing wound, and that you know, definitely sure, even if you can have the best supplies there, because of the causative agents behind this wound, it is a non-healable wound. What we then say there is that you can use them. For example, you can use betadine to dress that wound, just to control the odor and kill the bacteria. Because even if the betadine ends up being toxic to the viable cells, really, there's nothing that will heal this body because of different factors that inhibits it or due to the etiology of the wound. So at this point in time, when it's a non-healable wound, the goal is not to treat or heal it at all, but is to keep it moist. But then we have to monitor if then is my wound not extending due to these supplies. Sometimes there's crystal violet. You find that this one will keep the wound so dry. So we need to balance, but we can use them when we are dealing with non-healable wounds or malignant wounds, if the goal is not to heal at all. But if then it's for healing, you find that when your wound is granulating and developing those epithelial cells, these supplies then destroys those epithelial cells. So you will find yourself rotating now and again, instead of healing that healable wound, you keep on making it wider and wider, and then extending suffering. Sometimes in our facilities, we don't have supplies, and for us who usually go for home base, and then when you talk with the clients, they will say that, oh, there were maggots at some point in time, but I managed to finish all of them through betadine, through honey, through pawpaw leaf. You see the purple skin there. So they cut, sometimes we use salt water just to clean the wound, because salt water has that effect on wound cleaning. So these are some of the non-pharmacological things that clients use to manage their wounds, especially when there is a maggot. Sometimes they bring the dress with brown bread so that the maggots will leave the person and come to the sugar. So yeah, even honey, when it's in the wound, the protein enzyme that is produced by the antibiotics at the base reacts with the honey to produce a sufficient hydroperoxide. So then it turns into hydrogen peroxide. So you reap the same effect, but that is so healthy for the skin. So that's what normally happens with honey. And with the pawpaw acts like adaptic. So it has this sucking power when there's a lot of oxidate, the green one, and then it suck the oxidate part. We need to watch it very closer, because at some point it may lead to bleeding when it has drained a lot, then it keeps on draining everything. Yeah. So sometimes you find that the wound is engorged on top, looking inside, which shows that the base is so dry, so you can't put pawpaw there. You better put the honey and stuff. Auto control, there are many things. You can also mention your own, but we know the common ones. We use vinegar to trap any smell. Maybe we put it under bed or by the door, so it can take. We have kitty litter, charcoal. You know, charcoal, when you have put some perfume there, then they are exchanging the audio with the house. So then we harness the principles of diffusion and osmosis and stuff. And then we encourage ventilation. Yeah. And then, but the basic thing to deal with all is to decrease bacterial burden using antibacterial cover, either systemic or topical, based on the nature of the wound. And then for the oxidate, we have the alignants. So they are bacteriostatic and homostatic. So they do the exchange. These are the alignants. So they are like this, or sometimes they are like this. So sometimes they are a little bit straight tubes, or they are squares, depending on the wound base that you have to deal with. The deep ones, you will need this one, but for flat open wounds, you need this one. So they absorb and do the exchange. And then we have the up forms. We know the forms. We have adaptic, the ones that we know. And then we have also cotton pad gauze. We also use cotton gauze, square gauze for this oxidating wound. But then we need to understand that when you are going to dress with the gauze, it will do the absorption, and then you have to watch closer the wound, because it may absorb and then end up draining. And if you are going to put dry gauze in a wound, be careful that when you are removing it, it might have stick on the walls, and then when you remove it, and then it traumatizes the wound. So instead of moving forward, you keep on going back and forth. Okay, so then the principle is you don't leave wounds open, because one of the things we want to protect the wound from external infection. So we want to keep it clean so that the body can be in a position to thrive and then build itself up again. So then we have to close the wound. Whenever you are using strappings, we all know there are those sticky strappings. When you remove them, they can tear the perineal skin or the wound, the top part of the wound. So we want that are friendly, because sometimes the wound, due to the oxidate, the skin is fragile. So we don't want to inflict more pain and to our patient when they are changing dressings. Yeah. So sometimes we minimize tearing. So yeah, as I've mentioned before. Sometimes there's bleeding, so sometimes there is tranexamic acid to prevent dressings. But then also it's very important that you check if your patient is not taking anticoagulants, like he is taking aspirin or is taking NSAIDs. Sometimes there are these dilemmas that my patient is having arthritis pain and then he has this bleeding wound. What should I do? Because Diaglo is working well with the bones, and then I have to, so need to do the reassessment and see if you can balance the two. And then whenever there's acute bleeding, we minimize the dressing changes, so we look for malignants. So that will take a little bit longer time so that we can put pressure on that area. And it's very important that then we need to do goals of care and advanced care directives with the patient and the family, especially when the wound is bleeding and spotting, because that one comes with trauma. We are natural that when we see blood, we think of life being compromised. So, yeah, we need to then discuss with them and talk of advanced care directives. And when we are talking about advanced care planning and goals of care, it includes blood transfusion. So, will the patient appreciate blood transfusion so that then we don't take patient to hospital for blood transfusion that they do not know, they do not want, and end up putting ourselves in trauma. And also we use crepe bandages to put pressure on that site. So we put pressure, like we know in general when you are getting an injury, then we put and then another thing is to use sedatives, especially lorazepam, because the patient cannot rest seeing the wound bleeding now and then, you see. So we need to take some sedatives and help them rest and sleep. And for this one, we prefer using lorazepam because it refreshes the patient while achieving the sleep. The others are not good for achieving to deal with insomnia. And then we have wound care clinical interventions that we can do on a normal basis. We monitor the skin at every visit, whether it's for consultation at the hospital or it's a visit in the ward or it's a home visit like we do at hospice. We monitor the skin. We look at how intact the skin is around the wound, and then also to assess for any pressure ulcers development sites, and then look at maceration by the oxidate. We evaluate the type of skincare practices. What is the patient doing to maintain skincare? Are they using Vaseline? The first thing you will see, you will find the heels or the feet very dry and cracked. Then it tells you that they have poor skincare practices. So you need to help and assist them to apply Vaseline, normally Blucy. They're looking for expensive lotions to keep the skin moist, and then look around issues of oral intake in terms of fluids. Remember, dehydration is a stumbling block to wound healing. Assess patient and caregiver ability. Always you look at their ability to manage the wound at home, and then you train them. Education and the demonstration is very important in palliative care because we want them to be active in the care of their loved ones. So we need to educate them. When we have seen those maladaptive behaviors, then we address them, then we teach them how to do it. Minimize exposure of skin or moisture from incontinence and perspiration or drainage, as we know that moistening of the skin will lead to more pressure ulcers and more wounds. So we minimize that one. We don't want that, so that we have adult diapers, we have linen servers, we check the mattresses, we look for Macintosh. So those are the things that we normally provide, even us here at Hospice when we reach them home. So yeah. Currently, even in our medical stores, if you order adult diapers, you will get them from medical stores. So they are there. Let's order them so that the bill can be informed in the car that really our patients, they need adult diapers. Even you are using the adult diapers, also sometimes look at circulation and stuff. When we are dealing with these wounds. Evaluate need for specialty or matters, as I've mentioned, cushions, and then look at the nutritional status, evaluating, bearing in mind the ethical principles that comes with it. Then assess and manage woundedness, and that one we cannot overemphasize. Actually, in our next module that will start, I think on the 5th of June, which is our next session, we'll be looking at supporting patients and their families. One of the issues that we have, palliative care in general, it's pain and symptom management plus psychosocial support. So without pain and symptom management, without psychosocial support is not palliative care. And psychosocial support without pain and symptom is not palliative care. So we are trying to bond these two. So we will be looking at now that we have done pain and symptom management, how can we do manage and assess woundedness? And most of the clients find that now they are not even suffering from the wound that we see, but the wound has created another psychosocial wound, spiritual, emotional, social. So then we have to assess and manage that one because it has a major role to play in the total pain management concept. So we have to deal with that one. So for that reason, in our next module, we will be looking at how do we assess and manage woundedness. And then look at deficit in terms of nutrition. So then we teach them how to do that. If we can, we even consult with dietitians on how best we can do that. Actually, wound care, especially chronic wound care or non-healing, it requires the input of the multidisciplinary team or the IDT team, interdisciplinary, because really we need one another in managing these wounds. And then also controlling moisture, as I've mentioned that one. As I've mentioned before, the risk we have started. Another thing that we need to do is to do documentation. There's nothing much so painful that we do most of our activities and then we cannot document. For us at Hospice, whenever we are meeting a client or visiting them home, we do our assessment using our tools. But then before we leave the family, we then do we leave our prescription notes with them so that whenever they go to any facility, they can present our prescription sheet with our visit history and our intervention. So it's very important to then document what you found and what were the plan and looking ahead. If any task left, document it so that any clinician that will take over again, you do that. So you document everything, even when it's going to be reviewed and stuff. Maybe in summary, the clinical practice is that whenever we are managing a wound, we need to consider one, the local wound care. When we're talking about the local wound care, we are dealing with the wound at its best, the actual wound that we can all see. So we are saying that let's manage that one well, let's put all the wound care principle, dressings, assessment and stuff, and manage it very well. And then another thing is that one of the principles of symptom control, if you still do remember, is that we need to treat the cause. So we need to find the cause of the problem and then manage it very well. So sometimes you don't need to deal with the symptom on top, which is the fruit. We need to do root cause analysis, find out what is really causing this problem. So we can determine together with the patient, is this reversible or non-reversible cause? So for reversible causes, let's treat the causes. For non-reversible, let's continue with palliation. And always, whenever we are dealing with the wound, let's look at in a comprehensive or holistic approach so that we can then look towards the goal of achieving the quality of life, which is the core mandate of palliative care, which is to increase quality of life and reduce suffering. So I can say these are the things maybe we need to understand when we are dealing with chronic wounds or in wound in general. Thank you so much. I think this is the end of my short slide presentation on dealing with chronic wounds that we see. As a multidisciplinary approach, we need to understand that we need the ITT. There are specialists. Sometimes when you have access to specialists, they can come and assist you. Some specialists will find that they require some certain amount because sometimes they are private. So engage them and then they come at the patient's cost. So yeah. All right. May I give you colleagues the opportunity if someone wants to add on how best have you deal with these wounds? Maybe we can also learn from what has worked for you. Yeah. we can share before I will go for our case presentation by our RFM team. Can I give us the opportunity to share? If anyone wants to share, can I give you the opportunity? If there's something you want to share in terms of chronic wound management. Or everything I said was okay. Yeah. Okay. Yebo Malignant.
Good afternoon, everybody on the session.
Yes.
Thank you, Sandile, for the presentation. For me, it was very clear. One thing I really want to say is the frustration for those caring for someone with a wound cannot be understood by someone who just comes and goes. But thank you to everyone who takes the time to assess, help them live with someone with a wound, because it is a terrifying situation, especially for chronic wounds. Worse when they get infected and we know that they're not going to heal like we're presenting. So it is something that we need to take to heart and really appreciate ourselves for taking that time to be with the family and the patient during those difficult times of their life. And it is really taxing. So thank you for the presentation and the empowering information.
Thank you, Malignant. I can see Nancy Geleno. You can unmute and talk.
Thank you for the presentation, Mr. Mahlang. I wanted to ask, I have seen something like raw pawpaw as a dressing, that how to prepare it to do the dressing. You chop it or you crush it, then put on the wound. Can you please explain?
Thank you. So the pawpaw, so it is said that when you use the unripe pawpaw, as I've shown it there, so you cut the scumba, I don't know, the skin, yeah, of the pawpaw for the sake of our friends from India and across Africa. So you use the skin of the pawpaw and then you apply it on the wound. So it's like a dressing, like you cut the skin of the pawpaw, then you apply it on the wound, like you will do even with bread. You will take the bread and put it on top of the wound, if there are maggots. But this time around, if there's some oxidate in the wound, so you wanna put it there, then there's scientific exchange between the wound and the pawpaw, and then yeah, it has those antibiotic effect, but it has to be the unripe one. So you don't crush it. I'm aware that for gastric ulcers, the same raw pawpaw. There's one of our fellows who does palliative care also, they come to us, share his Facebook page that also raw pawpaw to treat gastric ulcers, but where you crush it, you chop it and put it in water. But this time around, you don't chop it, you just use the skin of it. And then you use the other side, the white side of it on top of the wound. And then you put your dressing and cover. And then later you come and yeah. But sometimes you find that the community or the class, they know. Sometimes they are scared to tell you what they've been trying to use. So if you sit down and then discuss with them cultural what they've been using, they tell you, oh no, we use this to heal the wound. I've heard that they also use mihlabel and stuff to heal wounds. I'm learning also in the field through the clients. I've been humbled by clients because they know more, especially on these traditional alternatives. I hope I've answered Nzigi's question.
Yes, Mr. Mahlangu, thank you.
Yes, but then they must be very careful because it can lead to bleeding. Yeah, it must be monitored very well. The day you will use brown bread to remove maggots, you will stop eating brown bread. Yes, Sister Marta.
Thank you, Mr. Mahlangu. I want to do the follow-up on the pop of wound dressing. I heard that sometimes you just peel it, the skin, and then you have to grate it and use it. That's what I heard about it. It's you just grate it and then using a grater and then use it for the dressing. Yes, especially for, and then you can even pack it on the wound and leave it for 2 days. If I pack it today, I can leave it up to 48 hours. After that, you can then continue with the wound management.
Yeah. So let's plant mapopos in our homes. They will help us a lot. Thank you so much, sister, for that. Yeah, these are the things we need to embark on research and see if we have a goal in our country and see evidence for ourselves and see how they are working. And anyone else I'm leaving behind before we can take RFM case? Okay, can we see RFM case, colleagues? Can I share the screen with Ndudi? Okay, you can go ahead. Ndudi. I think you can see it now.
Good afternoon, colleagues. My name is Nontsikelelo Ntuli from RFM Hospital, Manzini, Eswatini. Be sharing our presentation of a 68 years old male who have parotid cancer. The main problem or concern we have about the client is that he is having a recurring mass on left cheek. Ulcer have developed into a large septic wound that is oozing a foul-smelling, clear discharge. Chief complaints. Patient is complaining of severe pain on left cheek and headache. Pain score ranges from 8 to 10/10. Need wound dressing and change of wound dressing more often to promote rest and comfort. Sometimes feels weak and dizzy. Assessment of pain. Pain is somatic. It's on left cheek, radiating to left eye and forehead. Pain score, it's 8 to 10/10. The pain is non-specific. Relieving factors, it's pain medication. Patient doesn't walk properly and the pain causes lightheadedness. He uses 9 opioids and strong opioids. The medication has a partial to complete effect for a while or longer. Physical aspect assessment. Patient is mentally stable, well nourished, voice loud and clear, is well groomed, bandaged on left cheek. Psychological aspect assessment. No past psychological history. Patient feels anxious and unhappy about his recurring wound. Social aspect assessment. Patient is ambulating, is a pensioner. He was working as a technician. Education, he went to tertiary institution. Marital status is widowed. Lifestyle habits, patient drinks alcohol and smoke. Relevant health condition in the close family members, there is no history. Other social related information, he stays with his children, daughter-in-laws and grandchildren at his home. His family supports him. He likes reading and usually borrow novels to read at home from RFM Social Welfare Office. Spiritual aspect assessment. Patient is a Catholic. Significant medical surgical history. Patient is a known art patient on treatment since 2013. No history of hypertension and diabetes. It developed a painless mass January 2022, which became bigger into a large septic wound. He did biopsy September 2022, and it was found that patient of metastatic carcinoma. Patient was referred to the oncologist in Manzini Hospital for further management. At Manzini Hospital, he was initiated on chemotherapy and morphine syrup. Chemotherapy worked very well and the wound decreased in size. Before it was completely healed, a small mass was noticed near the healing wound. The mass developed into a large septic wound that is oozing a foul-smelling clear fluid. Patient reports that he is taking chemotherapy drugs orally from Manzini Hospital. He usually goes for refills and reviews at Manzini Hospital. He is changing wound dressing at RFM and receives pain medication for pain management. He comes once in a week for dressings to minimize touching the wound as it may trigger or increase metastasis. He is always complaining of severe pain when he comes for change of dressing, and he gets diclofenac IM whenever he comes. Relevant past medications. Patient was receiving morphine syrup 10 mils orally 6 hourly, bisacodyl 5 mils orally once a day, amitriptyline 25 milligrams orally at night, fluoxacillin 5 milligrams orally 4 times a day, Allergex eye drops, benzyl benzoate, Ventolin spray. Current medications. Patient is on morphine 30 milligrams orally 2 times a day, bisacodyl 10 milligrams orally at night, paracetamol 1 gram orally 3 times a day, diclofenac 50 milligrams orally 3 times a day, or Brufen 400 milligrams orally 3 times a day, ferrous sulfate 1 tab orally once a day, on TLD orally once a day, diclofenac 75 milligrams, IM stat, and the oral rehydration salt. Advanced care directives they are not yet discussed with the patient. Healthcare proxy, patient, yes, there is, it's the patient's family, the children. He is mentally stable. There are no concerns so far. Vital signs, temperature 34.6 degrees, blood pressure 87/67 millimeters of mercury, pulse 87 beats per minute, respirations 18 breaths per minute, oxygen saturation is 94%, ECOG is 0. Other symptoms, the pain is severe, there is no dyspnea, anxiety, it's moderate, agitation, it's mild, depression, it's mild, drowsiness and fatigue is moderate, nausea and vomiting, there is none, anorexia, it's mild, constipation, there is no constipation, there is no dry mouth, and patient is ambulating. Focus investigation. Since patient was complaining of dizziness, we checked hemoglobin and we found that it's 8.1. And we referred the patient to the doctor. The other investigation was done 2022, yes, which is the biopsy for histology, where it was found that the patient has metastatic carcinoma. Further care plan, patient is seen by oncologist at Manzini Hospital. He changes wound dressing at RFM once a week as per doctor's order, scheduled for counseling with the social worker. Thank you.
Thank you so much, Ntuli. Yes, here is our case, colleagues. I hope we have seen it. Maybe just to summarize, is to say that this is a 60-year-old male with parotid cancer. And the main problem here is that patient has this recurring mass on the left cheek, and the ulcer has developed into a large septic wound that is oozing a foul-smelling and clear discharge with pain score ranging to 8 to 10 and partially responding to opioids. Yeah, can I give opportunity to you colleagues to comment and advise how best the team can support him? Currently, the patient is booked for counseling with the social worker. Yes, Yebo. Anyone wants to ask or share something? What can be done with this man? With this oozing smelly discharge from the cheek. And he has a history of smoking and alcohol. Yes. Anyone wants to share something? How best we can deal with this situation? Is there anything we can do about this one? Or what they are doing, and we think it's fine, nothing we can add. And currently taking PO chemo. Yes, it's currently taking PO chemo. Yebo. Mamele. Ndimamele bahlobo bam. What can we say? Okay, what I can say is that one of the challenges with dealing with people who have substance use problem or history of taking substances like alcohol and smoking is that you find that the dosage of the opioids sometimes ends up not working very well for the patients. So the challenge is, I'm not sure if currently RFM you have the liquid morphine, but I would suggest that in your prescription, if it's Monene or you, consider the breakthrough dose, but you need to assess if it's the 30 milligram BD has no incidence of pain that usually comes up. So then it will help you to know if you prescribe the breakthrough dose, at least 1/6 of the daily dose of the patient, that is 60. So that one can help you maybe to manage the pain, because really when the pain is too high, especially the site of the wound is very distressing. So I would recommend assess for the need of a breakthrough dose for the opioid. If you do have the short-acting opioid, that can be very nice to have both long-acting and short opioid as a breakthrough dose. It can help in dealing with this pain. And then another thing that I think could be dealt with is the issue of monitoring very closely as coming every week. I think that's a good move to monitor even opioid misuse behaviors, so that you can determine if there is an opioid use disorder or there is a misuse, because really when we are prescribing the opioid, it's either well prescribed or not. So we need to monitor that one. And then I've got this experience that most of the times, as you are saying here, when the red blood cells goes down, also the BP goes down, and then circulation poor, and then the wound complicates. I think also monitoring the red blood cell density count will help you to manage the dizziness. At this point in time, I think doctors have their way of seeing if we need some transfusion at some point, but I've seen that once the red blood cells goes down, also the dizziness and stuff happens, and then the patient can even collapse. So we need also to sit down and see if those are possible interventions with the patient. And then the issue of dignity with the discharge. I think the issue of addressing the wound base and then choosing a dressing like adaptive or what, depending on the wound, because an malignant maybe would be doing well, but unfortunately we are not sure of how the wound appears, deep or shallow, but the malignants are very expensive. But then maybe getting something that will absorb the oxidate, if the patient can afford to come and change the dressing 3 days or so, and then we can schedule even that one to see that, because staying long, we may find that the oxidate will end up corroding the wound. I'm not sure if then the oxidate is not widening the top part of the wound, which is the perineum of the wound. The perineum of the wound is, if it's already dead, then it means the oxidate already is causing more havoc than we think. I think also adding metronidazole as part of your dressings will assist in dealing with this odor, because one of those things that will affect his dignity is the odor that comes with it. I hope their discussion with the social worker will include the goals of care. I'm hoping the oncologist will discuss the issues of the goals of care in terms of the chemo's purpose at this point in time. Is this cancer gonna be reversed or not? And then if the patient is aware of that, then I hope it can then align somewhere the plan you will have. Yeah, that's what I can share on my side. That maybe let's review the dosing or the opioid take and assess for breakthrough pain if it's there. And then, yeah, and then look around on the dressing if we'll need some absorbance forms or what, and what financially the patient can afford. I think it can do that. And then the family support also, I hope the social worker will cover that in their session with the patient in terms of how best they can support them going forward and what is the impact of this condition. I think also communicating with the oncologist as an RFM team in determining issues of prognosis and stuff so that we can be on the same page with the patient would also help. Yeah, those can be my small additions. Otherwise, I think the medication is doing well. Except maybe checking pharmacological burden. If he's still managing very well, that would be very nice. Seeing all those drugs working for her. Yeah, that's what I can say on my side. I don't know if I'm closing or leaving someone behind. How much I wish we can now share our feedback. So today, this is our feedback session. So we can now say that for symptom management, we have gone this far. And we are not saying this is the only thing to deal with the symptoms. You can click this, and then CPD points, we will be able to give you your hours. And for those who will be able to finish, there is that's what you call, there is this oh, I'm sorry, there's something that is disturbing me here. There is a post session test that we have. I'm sorry. For you colleagues, if you want to get our attendance certificate that comes with the number of hours you have completed. So the number of hours for this session, it's 11 session times 1.5. So it's around 15 for those who want to use our sessions as form of CPD. So we will have them, and if you want them, we are requesting that you do finish our post-test. It's an ungradable. It's just to remind us on what are the concepts we've covered in the sessions only. So just to remind us that. So it's a multiple choice. You will be just selecting what do you think is the correct answer. Then once we are done with it, we will be able to share with you our post-module attendance certificate that declares that you did attend these sessions and you were able to complete those hours. So then on our next session, we've already shared with you in our modules that we have another module coming. So we are hoping we will be able to request or invite our social workers to please don't leave them behind. We will appreciate their input in this course. There's a module that will be starting on the 5th of June, which will be providing supportive care for clients and families faced with serious illnesses. So conditions, we are requesting your support and your presence in these sessions. It's not a very long module. I think it's 11 to 15 modules. So it will take us around to November. So the first thing that we are going to look on the 5th will be dealing with the interdisciplinary team approach in providing palliative care. So we are requesting that we all come with our colleagues or allied workers who help us in supportive care, so that we can all learn together. This is a non-medical intervention. I don't think we'll ever see a drug there. It will be human interactions and conversations. Thank you so much. So that one will be on the 5th of June. So we'll have another module. But then I request that between this week and June, we'll be sharing an email with you via ECHO with the post-test, so that for those who will fill it, they will then get their attendance certificate from ECHO. Another thing we can share with you, colleagues, is that when you are using an Android phone, ECHO now has developed. We have an Android app. You can go to Play Store and look for ECHO. You can get the application, then download it and have it in your phone free of charge. So that's one of the developments that we have had in ECHO. Thank you so much, colleagues. See you on the 5th of June. For those who want the CBT points and the attendance certificates, please fill in the post-test shared in your emails. I hope by the end of today, it will be in your emails. Thank you. Bye-bye, everyone. See you on the 5th of June.
Bye-bye. Thank you.
Bye.